this seminar in the post-acute sequelae COVID-19 series that we've been having. And the next slide shows you that this is the most recent in a number of seminars. All of these have been that we have had in the past are available on a website, so you can continue to refer to them in the future, as will this one. Eventually, we will have a white paper that's out. So that kind of covers all of these things. I just wanted to point out logistically that the presentations will be recorded for transcription purposes, but also so that they can be reviewed in the future. We will be muting everyone, and including myself, so that we don't interfere with the speakers. We will have time at the end to have questions and answers, an answer session. Probably the best way to make sure that your questions are brought up is to put them in the Q&A button that is shown at the bottom here. So please do that. But you can also do some chatting. And then finally, just as a reminder, the next slide I think is very clear that the disclaimer, I'll probably say it as well as the others will. These seminars are not meant to provide any medical advice. So it will not be given nor should be inferred from these discussions. As I mentioned earlier, the hosts for this meeting scientifically are Dr. Jay Rappaport from Tulane University, who has been a very active member of our active program since its beginning, as well as Dr. Josh Feshel, who is a senior clinical advisor at NCATS. So these are two of my favorite people within this group, and I'm going to pass it over to them to do the introduction of our speakers today. So thank you very much, Jay and Josh.
Fantastic, Joe. Thank you so much. And the feeling is very mutual. So I am delighted to have the privilege of introducing not one, but two experts to talk to us today about two really cool topics that are coming together and that are really impactful and relevant for the long COVID and post-COVID conditions or PASC space. We're going to hear from Dr. Jane Burns and Dr. Shamim Namadi today on machine learning machine learning approaches to diagnosing pediatric patients with multisystem inflammatory syndrome. Dr. Burns is a professor of pediatrics at UCSD and is the director of the Kawasaki Disease Clinic and Kawasaki Disease Research Center at UCSD, and has a tremendous footprint both in the clinical and in the research spaces in increasing knowledge and improving care for inflammatory vasculitides like Kawasaki disease. Dr. Namadi is an assistant professor at UCSD studying how to develop computational tools and machine learning algorithms to really bring medical data to life in terms of phenotyping patients, tracking trajectories, and predicting what's going to happen to people so that we can treat them better sooner to avoid consequences like multisystem inflammatory syndrome. And so because we have two superstars today, that's all I'm going to say by way of preamble, and I'm going to turn it over directly to Drs. Burns and Namadi, and thank you both for being here today.
Thank you, Josh. And I'm going to speak. You're going to run the slides, and then I'm going to turn it over to Shamim. So I'm going to do the introduction. Next slide, please. I have no financial disclosures. Click again. And we were going to think back to March of 2020 when we were all faced with a new disease. And we didn't see it coming, but there was going to be a second new disease embedded in the first new disease. Next slide. We thought at the beginning as a pediatrician, because that's my training, my clinical training, that perhaps children were going to dodge the pandemic bullet, but such was not the case. And as early as April, we began to hear from colleagues in the UK about a disastrous condition in children that followed the peak of the adult COVID-19 disease in the community by about 4 to 6 weeks. And then it was recognized in the United States, and the WHO then made a pronouncement that this was actually a global issue. Next slide. So many case definitions abound, and the reason that we're giving the presentation today is, in fact, none of the case definitions that are out there for multi-inflammatory syndrome in children, or MISC, none of those case definitions as a clinician on the front lines really serve us well. So while the CDC case definition had to be pulled together quickly and we needed something to go by, there's obviously a lot of room for improvement, and this was really created as an epidemiologic case definition. But what we needed, what the emergency room doctors needed on the front line, was a way to recognize these very sick children and sort them out from the many, many other children flowing in through the emergency room who also had the features that you see here: fever, laboratory evidence of inflammation, a clinically severe illness. We see lots of very sick children in the emergency room. And as time has gone on, of course, the children who have been exposed to SARS-CoV-2, either by known infection in the household or simply being exposed to the virus in the supermarket without anybody knowing but are antibody positive, they are a huge reservoir of children who have positive serology for the virus. And yet that positive serology has nothing to do with the illness that they're presenting with in your emergency room. So clearly this was an epidemiologic definition at the very beginning of the pandemic, and we needed better tools for the clinicians trying to care for these children. Next slide. So we'll just say that it's a great epidemiologic definition, but it doesn't work very well for actually identifying these children. Next. So I have spent my career taking care of children with Kawasaki disease, which is another one of these diseases for which we have no specific diagnostic test, but we recognize a pattern of features as well as supporting laboratory data of significant inflammation. But I just want to point out some of the features here that had overlap with MISC. So you see the bloodshot eyes, the red lips, the swollen hands, the big lymph node, and the rash, most notably the rash. And some, but not all of these features, next slide, overlap with MISC. So this is a patient with MISC. So you can see that just based on the clinical features alone, and this is also reflected in the literature, where we all remember the call for alarm from northern Italy when they thought they were having an epidemic of children with Kawasaki disease, which of course turned out to be MISC and not Kawasaki disease. But these two conditions continue even to the present day to be confused by frontline physicians who may not be very familiar with either of these conditions because both of these are rare. So if you go to the CDC website, there are only 6,400 or so patients with MISC reported nationally. We've cared for 100 of those children in our hospital here in San Diego, Rady Children's Hospital, but it's a rare condition. And similarly with Kawasaki disease, each year in the United States, there will be about 6,000 children diagnosed with that disease. So how to tell these apart? And these features, as you might imagine, are also shared by children who have miscellaneous virus infections that are of essentially no consequence and will resolve without specific treatment. Next slide. So here are some of the features that we began to recognize that in a general kind of way could sort out the populations of children who had Kawasaki disease versus MISC. So in general, the children with MISC were older. At the beginning, particularly, we recognized this condition in teenagers, although now we're seeing it across the age spectrum. They had some of the clinical criteria for Kawasaki disease, including rash and bloodshot eyes. The complaints of abdominal pain, vomiting, and diarrhea were very common. So GI symptoms were more prominent among the MIS-C population compared to KD. And there was a very distinct difference in the ethnic and racial distribution of children with these two conditions. And in fact, this has persisted and really is a very strong argument for a genetic underpinning for these two conditions. So children of African and Hispanic descent were way overrepresented among our MIS-C patients, whereas it's well known that children of Asian descent are overrepresented among Kawasaki disease. Now, any child can get either of these conditions, but we're just talking about probabilities and numbers. So inflammatory parameters that you see here, C-reactive protein, these are all non-specific, and taken each one alone is not going to make the diagnosis or sort out MIS-C from KD. But there are patterns that we as clinicians began to recognize. And when you begin to talk about pattern recognition, you begin to think, I wonder if the computer could do it better. Next slide. So we pulled together data from our large database of Kawasaki disease patients. And if you can click again, we'll see that there were features of the laboratory findings that really were very unusual among our Kawasaki patients. So a white blood cell count less than 5,000 was only seen in 2% of this cohort that we had here at Rady Children's Hospital. And this is looking at data from over 1,000 patients that we had in our database. Similarly, a low platelet count, less than 120,000 cells, was also a rare feature, 2% in our Kawasaki group, but very common in the MIS-C group. And a low serum sodium was another feature that was much more characteristic of the MIS-C children than Kawasaki disease. Next slide. So the government rose to the occasion, and the National Institutes of Child Health and Development put out a call for applications, and we applied, and we're one of 8 groups chosen from across the United States with a large collaborative group that you see here to try to approach the problem of providing physicians with better tools to diagnose and predict risk in children with the spectrum of SARS-CoV-2 related illness. And our group really focused on MIS-C and how to differentiate that from Kawasaki disease. So today we're really going to focus on the bioinformatic machine learning AI team led by Shamim Namati. And we're not going to have time to talk about all the other incredible work being done by the team shown here. Next slide. So because as clinicians, we saw that there were patterns that we were beginning to recognize, we thought that this might be a ripe project for bringing in an artificial intelligence group that could develop algorithms that also worked on pattern recognition. And so I'm going to turn it over now to Shamim Namati to tell you a real success story. So there's been a lot of frustration in research about trying to understand exactly why the children who get MIS-C get it and exactly what the underlying molecular pathophysiology is. But we're going to share with you today a real success story, which is delightful and wonderful and has been a real shot in the arm to the team to have some positive findings. So I'm going to turn it now over to Shamim.
Thank you very much, Dr. Burns, for the wonderful background and clinical context. I'm Shamim Namati, Assistant Professor of Biomedical Informatics at UC San Diego Division of Informatics. All the credit for this work actually goes to my PhD student, Jonathan Lamb, who has been working tirelessly for the past year on this project. Jonathan could not be with us this morning, but all the credit again goes to him. Okay, so I will start by giving an overview of the data set that we used to develop this model, followed by a description of the model, and then finally about the state of implementation of this particular clinical decision support tool. Next slide. So I'm a co-founder at UCS CIGIO, which is focused on dissemination and commercialization of AI-based clinical decision support systems. Next slide. All right, so the first thing that Jonathan did as a part of this project was really a monumental task to curate a data set of febrile control patients as well as post-hoc disease patients and patients across 3 different hospitals. As you may have heard, about 80% of task of building a machine learning model is about sort of data cleaning and curation. So this was the first major challenge, and we managed to complete that fairly rapidly. As if that wasn't enough, Jonathan put together another data set of 175 MIC patients from 16 different hospitals. There's a small little map that shows the diversity of this patient population. And as you know, with any type of model, it's really as good as the data that goes into it. So we try to make sure that the data set that we are using is as diverse enough. In particular, the data set included 17 laboratory measurements in addition to age and 5 clinical signs, such as rash, etc., that Dr. Burns mentioned earlier on. In terms of the gold standard labels or diagnosis labels for this data set, we essentially followed the CDC and American Heart Association guidelines, but all of these diagnoses were done prospectively by a clinical team, and they exercised the judgments to diagnose these patients. In terms of the model, so if you go to the next slide, we decided to go with a 2-stage model. In the first stage, the model makes a determination if the patient is at risk for MISC or not. So the setting again is patient comes to an emergency department, and we collect the 17 laboratory measurements and 5 vital signs plus age, and we fit it to a 2-stage model. In the first stage, the question is whether the patient has MISC or not. And then among the patients who do not have MISC, we pass it to another classifier, another model that classifies these patients in terms of febrile control versus Kawasaki disease. Next slide. All right, so if you're interested what the specific information that goes into the model are, here is a list of some of these features or parameters that goes into the first stage algorithm. We are showing here these parameters in terms of their odds ratios based on a simple logistic regression model. And as you know, a smaller odds ratio like 0.19 reduces the risk for MIC, and then larger odds ratio means the variable increases the risk for MIC. Next slide. We also have a list of variable. Next. That was used or went to the second stage algorithm for characterization or classification of KD, Kawasaki disease patients. And you see the list here. So the traditional type of models, essentially what they do is they assign a risk to the individual variables. And when a patient comes in, you go through the series of features and you just do a check mark. And if they are present, then you assign the corresponding risk, and then you add up those numbers in what we call a logistic regression model. And based on that, we make a prediction. So while these models have been used widely in the past, one of the shortcomings is that they are not able to capture all the multiplicative risk factors. I give you one example. let's say a patient comes in with low temperature and who is immune system compromised and has a high white blood cell count. So the combination of factors here together, they make a difference. And you may say that this patient is at risk for infection or sepsis. So as you see, often it is the case that multiplication of several factors are important, and the model that we specifically use is capable of capturing that. The specific type of the model is called neural network. So I'm going to spend the next 2 or 3 slides to provide a very brief overview of what neural networks are. Next, please. Okay, so artificial neural networks, they were essentially inspired by some of the earlier studies of the primate visual cortex. In particular, back in 1960s, Hubble and Wiesel, they were electrophysiologists. They were essentially putting electrodes into different regions in the brain, and they were asking that the neurons in those areas are basically responsive or stimulated by what type of visual stimuli. They were really trying to understand how our brain is able to do pattern recognition and make sense of this complex visual scenes. So as they started their studies, when they looked at some of the neurons at the level of the retina, they realized that these neurons, they were sensitive to shades of gray or very basic colors. But by the time they went a little bit up, they looked at LGN and then V1 regions, they noticed that the neurons are becoming more responsive to complex features. The really interesting part is that this complexity arises actually from those sort of first level sensors that are in the eyes, and you're capable of detecting very simple features. Sort of by analogy here, our laboratory measures, we have our vital signs and clinical signs, and we are trying to construct a complex scene, which is the diagnosis of KD or Kawasaki disease. And similarly, the brain is trying to construct the visions based on very primitive sensory inputs to the brain. So this sort of inspired some computer scientists later on in 1970s and 1980s to try to build very simple versions of these neurons and the hierarchy of neurons in computers, and try to see if this type of what we call artificial neural networks are also able to perform pattern recognition. Next slide, please. So the picture that shows here on the right side bottom basically shows the example of an artificial neural network. This particular network has 15 different inputs, and then it has something we call hidden layers. These hidden layers, essentially what they do is they combine information from the individual input features. So this is your, again, clinical signs and as well as laboratory values. And they come up with something we call intermediate constructs. You see this X21, X22, etc. What these nodes essentially they do is they weight the importance of different variables. And then finally, at the last layer, they combine them together to make a determination for the type of diagnosis that we are interested in this case. So it turns out this type of networks, they have shown a lot of promise in industrial applications for voice recognition, machine translation, object recognition. If you have a iPhone, you talk to Siri, Android phone, you have voice recognition built into your phone, you're probably already using one of these models. As I mentioned, they are very good at identifying multiplicative risk. And so we decided to use this model in the context of our classification task. One of the shortcomings of these models is that they are known as black box models. When you think about the complexity of these models, it's really hard to know what exactly they are doing internally. And that has been one of the criticisms. But as I will talk about, we try to address this by utilizing some novel methods of explainability that I will get into in a bit. Next slide, please. So, okay, so here's an overview of the model. It has two stages, neural networks. In the first stage, we fit in all the input features to the network, and we make a determination for whether this patient has MISC or other types of febrile illnesses. Next slide, please. So among these other groups, we, next slide, we make another determination. So actually go back, we make another determination by fitting the same features to the model and asking the question that among the non-MISC patients, who are the Kawasaki disease and which ones are what we call febrile children in general. So this is a two-stage model, and really in close conversation with our clinical team, we thought that given the ongoing pandemic, this model is most clinically useful in an emergency setting. Okay, next slide. So, yeah. So one of the interesting features of this model is that you may have heard the sort of the term, garbage in, garbage out, that if the quality of the data that goes into any type of model is not good, the output is not going to be very reliable. So we try to build some reliability measure into our model. The underlying algorithm is published in the Nature Digital Medicine, and essentially says, artificial intelligence model learns to say, I don't know. So the idea here is, once you train a model such as this on, let's say, data from hospital A, traditionally, if you look at panel C, you input the data, all the clinical features to the model, and you make a prediction. Whereas in our setting, we carry examples of successful prediction from our training set, examples of Kawasaki disease, KD, as well as febrile children that the algorithms saw in the past and made correct predictions. And then once we go to a new cohort, a new group of patients, the first thing we do is we basically ask the question that, has the algorithm seen an example like this in the past? And is the algorithm able to make confident predictions? If the algorithm cannot confidently make the predictions, then we put a tag of indeterminate, or basically I don't know, to these examples. And among the patients that the algorithm can confidently make the prediction, we produce a label. We say that the patient is MIC or KD. So this is a nice safeguard around this type of algorithms that enables the model to not only detect type of inputs that are maybe of not highest quality or there's missing data, but also if you deploy it in a new setting and the characteristics of the population changes, then the model is able to detect that and not make erroneous predictions. Next slide. Okay, so if you look at our publication, we show that using this approach, we can significantly reduce the false alarms associated with these type of methods. In fact, we showed that you can reduce false alarms by 75%. If you're a clinician on this call and you work at the bedside, you understand the sort of burden of false alarms. And so we spend quite a bit of time into reducing false alarms, making sure that this model is quite accurate. Next slide. Okay, so in order to validate this model, this two-stage model, we relied on two different data sources, as I mentioned earlier on. The first one, which we call our internal validation data, it was used to train the parameters of the neural network. And we performed what is called tenfold cross-validation. It's really a fancy name for saying that we used 80% of the data for fine-tuning the parameters of the model, and then we left 20% of the data on the side so that we can assess how will the algorithm performs on a patient population that it hadn't seen in the past. And then we repeat that process 10 times, and the numbers that you see in the table, they report the show the median and the interquartile range of the performance. So what the takeaway message here is that for the first stage, the model is quite accurate. With the neural network, we get 96.4. It turns out with logistic regression, we also got a similar performance. But in certain cases, the neural network has much better performance in terms of reducing false alarms. For the next stage, which is distinguishing among febrile control patients and Kawasaki disease patients, we also push the data through the model, and the neural network produced an accuracy of 90% for distinguishing KD from FC. So these are all internal validation. Next slide. In order to get a better grasp of the generalizability of this model, we relied on a fairly diverse data set across the United States. Dr. Burns worked very closely with her collaborators across the country to gather data sets from, it doesn't say the exact numbers here, but across over 100 MIC patients. And we were able to show that this model, once it's locked and all the parameters are fixed, is able to make quite accurate predictions among the MIC patients. So for the first data set, we got a performance of sensitivity of 93.8%, second one 95.9%, and the third one 90%. So it shows that the algorithm is quite effective at picking up MIC patients. Next slide, please. Okay, so as Dr. Byrne mentioned earlier on, there has been a lot of publications on various types of machine learning models. Many of them are based on retrospective data. Here, there was a really urgent need, and our clinical collaborators wanted to see if they can evaluate this model in a prospective setting. So Jonathan worked on building what we call a web calculator. Essentially, it's a URL, it's a web link that if you log in and if you are within the hospital, you can load this simple calculator and you could put in all the laboratory values and clinical signs of these patients into the calculator, and then you can use that to generate risk score. So next slide. So in this case, the algorithm, based on the selections that were made, basically says that this patient has a very, very high chance of having MISC. I alluded earlier on to this notion of neural networks being black box type of classifiers. We utilized some of the advanced interpretability or explainability methodologies to actually open the black box and produce not only a risk score, but also a list of top contributing factors to the risk. So the bar plot that you see here is essentially showing the contribution of different variables to the model's predictions. And it's ranked in the order of importance. So this is nice because it's telling us, what are the factors that the model is looking at. Having said that, it doesn't tell us about the internal working of the model. It tells us what it's paying attention to, but we don't really know how it's utilizing that. And you may consider that as a form of disadvantage, or it might be an advantage because, we have our sort of human and clinical way of doing diagnosis, and the machines are doing their own complex forms of pattern recognition. And really, the power of using these type of systems is in bringing together humans and machine in a symbiotic, relationships, and having them being a second pair of eyes. And the intended use of this system, again, is to provide a second pair of eyes. They are not intended for making a final diagnosis. The output of this model are typically presented to a clinician that they evaluate all the top factors, and they perform chart review on the patient, and they are the one who come up with the final diagnosis of either MISC or KD. Next slide. So that's all I've got for today. I'm very happy to answer any questions. Thank you again very much for this opportunity. I just wanted to say that I've been working in this domain for the past 10 years. this project has been really, really amazing. This is really about when there is a clinical need, an urgent clinical need, and there is a very compassionate and driven clinical team that joins us with another interdisciplinary team, in this case, informaticians, how much you can accomplish in a short period of time. I'm very, very humbled and honored to be working with Dr. Burns on this project. Thank you very much again.
Outstanding. Thank you both so much, Drs. Burns and Nemati. This is truly impressive work. I'll remind everyone that you can submit questions either in the Q&A box or in the chat. We're watching both, and we'll happily field those questions. We have a good amount of time for discussion, which is great. While people are thinking about their questions and comments, I want to talk a little bit about what you just touched on, Dr. Nemati, which is that I think this kind of work that you've presented is a really shining example of what happens when you bring these multidisciplinary teams together of clinicians and informaticians and computer scientists and clinical researchers. And I think this is a really sort of rich example of what can come out of those kinds of collaborations. And so before we kind of dive into your science, because we could certainly do that, I want to invite both of you to comment a little bit on what's your secret sauce? How have you made this work so well amongst this group? Because it looks, at least to me, and I think to everybody watching, like it clearly has worked well. And so you've figured some things out. It would be really exciting to hear your thoughts on that.
I'd be happy to jump in first. I have spent my career trying to bring in other eyes, other ways of looking at the world to focus on Kawasaki disease. So I realized early on in my career that I was one person with one way of looking at the world, and that if I wanted to move the needle forward on really focusing on this disease, I needed to bring in people who could look at the disease through a number of different lenses. And I have to say that the richness that I experience every day in my career is really fed by this interdisciplinary work. So I would just say to people working in your research silo out there, if you haven't tried it, give it a try, because it will enrich your life. And there is nothing more fun than listening to conversations of colleagues speaking a language that is English, but a language that really is foreign to you, and just marveling at the way in which different disciplines can take the same problem and look at it in different ways. So that's a rich experience that makes every day better. And I look forward to our once-a-week meetings with the bioinformatic team. It really makes a difference to talk to each other. So this isn't something that you can do by email. It would be even more fun if we could actually be together in person, but we've got a pandemic, so we're not doing that. But it takes real interaction. You have to make the time to sit down, quote unquote, virtually together and share ideas and bounce things back and forth. Otherwise, it doesn't work. So over to you, Shamim.
Yeah, no, I mean, that's really what it is. And I should mention that it really takes a village. I mentioned, Jonathan, but, we have a wonderful department of biomedical informatics at UC San Diego. And I think one of the features of this department has been its close proximity with the hospital. We work very, very closely with the hospital clinicians. I'm an engineer by background, Jonathan, computer scientist by background, but we are really embedded in the hospital. And so what we do is really guided by our clinical collaborators and having that close interactions on a, we meet once a week, but we are emailing back and forth every single day. That makes a huge difference. it has been really, really amazing to receive feedbacks from our frontline clinicians, amid this pandemic. It's really a humbling experience.
Wonderful, thank you.
What Shamim might be referring to is that when I use the calculator at 11 o'clock at night, I've been on call for the last 2 weeks, and we're flooded with MIS-C patients right now. And I use the calculator, and it supports my clinical impression. I'm pretty excited, and so I shoot him an email, and to Jonathan as well.
That's excellent. Actually, I was going to ask, thinking about the ultimate, or the endpoint of translation and implementation of a tool like this that you've collaboratively developed. If you had any initial impressions or feedback or ideas about it, but it sounds like yes, you've really been able to see it in action and in a helpful way.
So when Shamim said it takes a village, those words are very, very true. And we have fabulous collaborators in our emergency department. And that's very rare, actually. You think, well, physicians kind of all work together. Well, no, actually, people can get pretty siloed in their parts of the hospital. But we've developed over many, many years a very productive relationship with research-oriented emergency room physicians, and they're part of this team. And so they have now rounded up, we're a training program, obviously, as most academic institutions are. And so they've got a number of junior colleagues who are really excited about implementing this. And so we do have a prospective study that's being designed partly to understand how it feels and how it works and how it's being used by the clinicians. So that prospective study is about to be launched. But we are using it, those of us on the team who are seeing the patients are using it and giving feedback to Jonathan and Shamim about how it's working.
That's excellent. And Dr. Manetsky has put a question in the chat that kind of expands on that a little bit, asking, does this tool help define how you might treat people that you are assessing, both with your clinical judgment and with this decision support tool? And I'll sort of add to that, or are there any plans to kind of build something like that in going forward?
So the two populations of patients that we're trying to differentiate between and then sort out the febrile control children who have non-life-threatening conditions. These patients need to be treated very quickly. That's really the goal here, is to make a quick diagnosis. And so I think when we say that this is a physician support tool, that's exactly what it is. It's taking your clinical impression, having the neural network look at it, and then having that feedback to you to either have you pause and question. For example, we had a child who ultimately ended up having pyelonephritis, so a kidney infection, but came in with abdominal pain and fever and high inflammatory markers, and we punched it into the algorithm and it came back 65% MIS-C. Well, 65% MIS-C, that would give me pause, right? Like I wouldn't jump in and admit this patient as an MIS-C patient. And that was good because we slowed down a little bit. We thought a little bit more about it. We waited for the urine results to come back. And then we saw that we needed to go in a different direction. So that's how it's working in my life.
That's excellent. It almost sounds like it lives somewhere between a decisional nudge and a consult, a collegiate, consult with a colleague or a discussion with a colleague, and both of those things are incredibly helpful when you're at the bedside. So that's great. Looking, I don't see any other questions that have been submitted, so I will toss one out more on the data side. Dr. Namati, you talked about the importance of the data that go into developing and training and then validating these models, the garbage in, garbage out idea. And I think there's increasing awareness of how important it is to have a sufficient quantity of data of sufficient quality to really result in something that's robust. And so, and in fact, I got an email just while you all were talking that there are new notices of special interest that have been published just today on helping to validate machine learning and AI models. And so can you talk a little bit about how you have thought in how you've maintained this multidisciplinary approach to address this very information science driven requirement for this kind of work?
Yeah, those are really great points. Over the past few years, especially, we have been hearing about, data sets that can be biased. One of the sources of bias is lack of diversity. So you build a tool and it works on certain patient populations, but it doesn't perform as well on others. So there are really a few things you can do. You could start early and really build a very diverse collaborators, and that's what Dr. Burns has been doing across the country, so that the data sets that you have are representative. And then on the algorithm side, really, to a large extent, you're at the mercy of the data that goes into the model. But what we were able to do with our Nature Digital Medicine paper, this method that we call it conformal prediction, we said, maybe we can put a boundary around the algorithm. And if there are, cases that the algorithm hasn't seen, it's not representative in the data, the algorithm will be able to flag it out and say, I don't know. So you may call it some form of algorithmic humility, that it acknowledges that it doesn't know. And that's a very good time to bring somebody else in to look at those cases. Sometimes it's due to missing data. And at that point, you might order an additional laboratory value, and then the algorithm might have higher confidence and make the right predictions. But yes, so, we are still in the very early stages of understanding this type of models. The potential for good is high, but also there is concerns for, again, inclusion and performance and not making discrimination. We all have heard of like these no-show algorithms that hospitals implement. And, based on their prediction of who may not show up, they may double book patients. And as you can imagine, certain groups with lack of access to transportation, they might be sort of discriminated by this type of models. So we are keenly aware of this. We don't have a silver bullet or gold bullet for this, but we are constantly thinking about this type of problems.
Excellent, thank you. And we've had a couple more questions roll in along the theme of the elements of the model, or the informative features of the model. And so related to, I'm going to group these questions together a little bit and say, one question that's come up is, can the informative features of the model, the variables identified by the model, actually then be used, do you think, to inform deeper mechanistic understanding of the biology and the pathobiology that's at work? Is the algorithm sort of whispering to you about places where you might look in your more wet lab kind of based mechanistic studies? And then on the clinical side, based on the informative features, could the algorithm tell you what you might need to think about in terms of additional tests, additional variables that could improve the diagnosis? I love both of these questions.
So maybe I can answer part of that, and then I send part of about mechanism. Dr. Burns can chime in. So definitely, that's an amazing question. One of the things we have been looking into is once we produce this list of most important factors and we keep track of those for historical patients, when a new patient comes in, we can use machine learning to say, find patients similar to this patient. And then we ask the question, in patients similar to this patient, in whom we made the right predictions, what variables were available? And based on that, make recommendations about a couple of additional lab tests. So that's really something that can enrich this type of approaches and make better predictions. In terms of mechanism, I let Dr. Burns to comment on that. But just briefly say that there is a sort of a attempt right now to incorporate more mechanistic models into machine learning algorithm. You might hear the term physics-based deep learning or physics-based neural networks, where you are incorporating some physics of the system or the biology of the system to the model, but we are not quite yet there. Jane?
So I would actually say that the computer is putting together patterns and understanding something about these patients and seeing relationships between the features that we as the clinicians don't understand. And I want to share that as an experiment, I was given the same patients that we gave to the computer for training. So these are my patients, but obviously I don't recognize them. And a list of 100 of these people were given back to me with just the data that the computer was given. And I was asked to make a diagnosis based on only the features that the computer had available. And it was almost impossible for me to do that. So obviously as clinicians, we're taking in all kinds of other information, visual information, intuition, lots of other things on which we base our decisions. The computer is seeing something that I don't understand and I don't see. And even with the Shapley curves that come back, when we look at the weighting, I'm often having the reaction, that's interesting that the computer thought that was important. So I think the computer is understanding something about my patients that I don't see and I don't understand. But I'm not sure, Shamim, how you're going to teach me to be as good as the computer.
Yeah, and the other point, I think with the traditional type of models like logistic regression, you've seen medical journals, these things we call odds ratio that says, what is the importance of different variables. It turns out when you have more complex models and you're looking at patterns of interactions, certain variables become important for certain patients in front of you. So we have this notion of global importance of variables versus local importance. So there was a question in the chat box that, whether all 17 variables are needed. And not for everybody, but some of those variables are important for certain patients. I use the example of, hypothermia in an immune system compromised elderly patients may tell you something about infection. Rather, on the other hand, fever would tell you something about infection in a younger patient who is not immune. So this type of interactions, it turns out these computers can pick up on those and make predictions based on those.
There was also a question as to whether the algorithm then stimulated more testing or would lead to more testing. And absolutely, we have what we call in our emergency room, tier 1 and tier 2 testing for suspected MIS-C. And the tier 1 lab features, which would be something that any clinic that had a laboratory in the world could run. So that's the beauty of this, is that it doesn't require a special PCR machine with reagents that are complicated or expensive. This is just routine. Everybody would have this laboratory data. But when we see the algorithm come back and it supports our clinical impression that this is MIS-C, then we do go on and do a second tier of testing. But the algorithm could really potentially save money and save time by preventing that more expensive and advanced level of clinical laboratory testing by steering you away from that diagnosis.
Outstanding points. We are right at the top of the hour. I was so involved in this discussion, I almost forgot to look at the clock. We are right at the top of the hour. I want to be respectful of your time and everyone's time. And I want to make sure to leave a moment to say thank you so much, Dr. Burns. Thank you so much, Dr. Nemati. This has been a truly stimulating discussion. Jay, do you want to have the last word?
Yeah, that was really great and really inspiring what you're doing. And I think it kind of gives us some peek into what the future of medicine may be and how such algorithms, will contribute. So thank you so much for your presentations. I thought we had a good discussion, a lot of interesting questions. So thank you very much again.
Well, thank you to the NIH for supporting this work.
Great stuff. Thanks, everybody, and we will stand adjourned.
Thanks.
Thanks.